Hello and welcome. So in this presentation, I'm going to discuss about what is called calcific tendinitis. So in this case, I have a case of calcific tendinitis which is affecting the supraspinatus tendon. So here we go. You can see at the insertion of the supraspinatus tendon there is an echogenic calcification. So that echogenic calcification at the insertion of the supraspinatus, if you look closely, you can see that there's a mild effusion around it. So the mild effusion around the calcification, it shows that there are some inflammatory changes which are taking place. So you can have an appreciation of, so when you're doing ultrasound, the dynamic images, or when there's movement, you can appreciate pathology better. So this is the one of the advantages of medical ultrasound, because you can perform it in real time, as you can move the shoulder joint and appreciate the pathology from different views. So I hope you are appreciating this video. Then if we come here, what we now have is a static image. So in this static image now, you can see the calcification nicely. So this is the insertion of the supraspinatus tendon. So you can see the supraspinatus tendon there. So here we do have got the subdural basa. So you can see there's no free fluid. This is physiological free fluid there. And here at the articular surface, what you are seeing there is also physiological free fluid. So this is the greater tuberosity of the humerus. Then you can see that the tendon is inserted nicely there. So this is the calcification that you can nicely appreciate. So you see, when you're doing ultrasound imaging, you have to zoom your image nicely so that you can visualize the pathology nicely like that. So here is the sample report of the findings on the image that you've seen. So the right supraspinatus tendon is visualized in long axis. There is a prominent hyperechoic focus with posterior acoustic shadowing within the substance of the supraspinatus tendon, consistent with calcific tendinitis, type 1 or type 2 calcific tendinitis. So the shadowing in our case is not quite prominent. You can visualize it in certain angles, but it all depends on how you visualize. If you visualize the shadowing, if you don't see significant shadowing, you can still report it like that. There are very dense calcifications. There are also very light or soft calcifications, which don't really present with posterior acoustic shadowing. So the calcification appears well defined and dense, located in the mid to distal tendon fibers, typical for calcific tendinopathy of the supraspinatus. Surrounding tendon fibers show mild heterogeneous echo texture, which may represent associated tendinosis or low-grade inflammation. No full thickness tear is identified. The subacromial subdural base appears unremarkable in this view, with no significant fluid collection. This is what I was showing you on the static image, that there's no effusion in the subacromial subdural base and in the articular surface of the supraspinatus tendon as well. So it's not a must that you must always report in the same format. So it all depends on your skill of reporting. So this is the impression or the comment. So the right supraspinatus calcific tendinitis with a sizable intratendinous calcification is noted. This is a common cause of acute or chronic shoulder pain or pain self-limiting, but frequently very painful during the resorptive phase. So this I just added it for academic purposes. So basically, you don't really have to put all of this in your report. So you can actually put the impression is insertional supraspinatus calcific tendinitis. So that's your impression or the comment that you can give. But this is just good jargon to correlate with the cause of pain to a refilling lesion, uh, whom you are used to. So don't really do this when you're doing your reporting. So the other issue is in terms of the recommendations. If you are not all that experienced, there's no need for you to give all these recommendations, but to put spices to your reported times. If need be, you can also give recommendations. Clinical correlation with the symptoms and the range of motion is advised. So if significant pain persists, consider ultrasound guided intervention. So this is a sample report on a case of supraspinatus insertional calcific tendinitis. So when it is now causing, when a calcification is now causing um, inflammation in a tendon, that's why you call it tendinitis, calcific tendinitis, because the calcification is the one that is causing inflammation of the tendon. So that's how the two are now joined. It doesn't necessarily mean that if you see a calcification in a tendon, it's causing inflammation. It can be there, but without causing inflammation. So if there's no effusion around the calcification, normally just report it as a supraspinatus calcification. Don't add the tendinitis part. But when there are signs of inflammation, so you can know if there is inflammatory exudate or fluid around it, then you can flag it and then decide to put the jargon is calcific tendinitis. Thank you so much. Don't forget to share these educational videos with your colleagues. I appreciate you. Thank you so much.